Welcome back to the Full Arch Podcast. Today we're going to be talking all about sedation, and the Colorado Surgical Institute is returning. Doctors Dhoon and Briskie are coming back, and they're going to be sitting down and talking with us about sedation in the full arch practice. We're going to be talking oral versus IV versus general anesthesia. We're going to be talking about the economics of anesthesia in the dental office, when you should be doing it yourself, when you should be bringing in a provider, how to find the right provider, and even the role of sleep medicine in full arch cases. We get into a whole lot of stuff here. We get very technical, and we go really deep on sedation. So I hope you guys are ready. Let's get into it. All right, everyone, I am back, and may I say we are back. The Colorado Surgical Institute has returned for another wonderful episode with us, and I am super excited because it looks like they're going to be coming on with us a little bit more regularly to get a little bit more in depth about a lot of different concepts. And as you guys probably already know by now, if you've heard their other episodes, they have a vast fount of knowledge, and I'm really, really fortunate and humbled to be able to continue to pick the brains of Doctors Taher Dhoon and Daniel Briskie. So welcome back, guys. I really appreciate it.
Yeah, thanks for having us, man.
Hey, brother. Sure. Yeah. Great to be on again.
Yeah, absolutely. And some exciting news. Briskie's got a newborn on the way in the form of a startup practice that he's going to be starting about the next 5 weeks.
You scared me. I was like, I haven't even heard about that.
No, it's way more scary than a baby. But hey, yeah, Briskie, you want to talk about that for a sec?
So you just motivated me to have the first kid as well. So I might as well do that now as well. So
get her done.
Go ahead and get all the stress out of the way, man. Yeah, that's good. That's good. You can name him after me, and we're good to go. It's actually like it's a gender ambiguous name as well. So tell that works great. I really appreciate it. I'm honored. In fact. But yeah, man, that's great.
That'll be the middle name. So I got you there. Yeah.
I'll take the middle name. I'll take that. But yeah, man, that's awesome. I'm really excited for you. It's been we're coming up on the year mark of Peachtree dentures and implants, and I was in a similar phase back in April of last year, and pulling my hair out, and I'm sure you guys have a whole lot more experience and knowledge than I see that Taher's pointing at his head, but you guys have a lot more knowledge and experience to guide you along, so you're probably having a little more fun than I did with my project. But man, startups are fun though. When it all starts coming together, it's a pretty beautiful thing, and I think there's a greater sense of pride when you finally kind of get that moment where you see that things are actually working. But yeah, man, that's awesome. So
I totally agree. I know that's not the concept of today's conversation, but getting into startups and all of that and actually like breathing life into a business as an entrepreneur is super, super, it's an amazing process.
It is, and there's rewards in and of itself. I mean, I remember the first time I walked my office space, and it looked like a early 1990s Olive Garden. And we had to do like a complete remodel and facelift, and it's practically unrecognizable today. Still a lot of things I wish I'd done differently, but when you just kind of walk in that space, and it's I think it was really my first time doing it, and it's so hard to see the David underneath the marble, but then as it kind of it gets shaped over time, and then one day you just wake up and you're like, oh, this is a dental practice, and we treat patients, and it's working. But yeah, I couldn't agree more. It's a very rewarding process. But
I got my first 3 phone calls on Saturday.
Wow.
And they were for implants. And as soon as I got the phone calls, I was like ecstatic. Yeah. And it was really cool to know that I was excited and not terrified and saying, oh crap, what did I do? Yeah. For sure. I think that was encouraging alone.
Yeah. I mean, the phone's ringing is another thing. Is like, I don't know. It's just somewhere in the process, I was just like, why would anyone actually call this office and try to come see me and get this going? You know what I mean? Like, I don't know. It's just when you're in a new office, it's like, who shows up to a place with no Google reviews? And, like, I just couldn't even imagine how it worked. And then it just happens.
Then they were like, am I speaking to the doctor? And then I said, yes. I'm like, they're like, wow, that's so cool. I'm thinking to myself, oh my gosh, I'm a doctor.
Yeah. I don't know. Right? I was my own reception for like the first, almost the first month. And I actually had to be convinced to move to the back office where, it had been laid out as a doctor's office. 'Cause I was always up front greeting patients and stuff. And my girlfriend had to kind of stop me. She was like, are you always up front like that? And I was like, yeah. I want to make sure the patients are taken care of. And she's like, the optics of that are not great. Well, she was like, I mean, people appreciate it sometimes, but in another sense, it's like, don't you have better things to do? I don't know. But yeah, again, I'm sure we can dedicate a whole episode to startups for sure. But what we were planning on talking about today was getting into sedation. So this is something I get asked about all the time, especially with doing a whole lot of full arch work is, I think people generally assume that patients are being sedated for this, at least at some level. I think a lot of times people are assuming, this is under IV conscious sedation, maybe perhaps general anesthesia as well. But I think it's also important to talk about the role of oral sedation and then kind of help people navigate through that whole spectrum and figure out where they should start. If you're looking to get into more complex procedures and you're dealing with the type of people that need this kind of care, then a lot of times you're going to run up against some anxiety, complicated medical histories and stuff. And so once you kind of start getting into that world, it's really important to know what you're hopping into before you do it. So how should we start? I think maybe we should start with kind of, how we all sort of waded into the waters of sedation and what that was like at first. Dhoon, you want to kind of kick us off there?
Yeah, for sure. So I waded into the waters via corporate and oral sedation, and they covered it. I think it's like $2,000 to get your oral sedation CE these days. And, it's we do have that offered through Colorado Surgical. But you can get that really in a lot of different places. So I think it's a logical place to start, unless you're like you and your friends where you're, hey, we're full arch docs and we do this on a regular, then I would just bypass and go straight to IV sedation.
Yeah.
Just get it under wraps, get it over with, because it's going to move the needle in a major way. But my evolution was I did oral sedation for 7 years. And when I was doing full arch, I'd bring in CRNAs and allow them to do a deep or intubation type of sedation in the practice for patients. And then the times I would orally sedate my full arch cases in the beginning when I was slower, I'd say half of them didn't end well because they start to get restless and you just can't keep them comfortable long enough. Yeah. If you're doing your arches in about an hour per arch, you can maybe do an oral sedation case. But if you're creeping up on 2-3 hours, strongly consider IV or CRNA or dental anesthesiologist related sedation.
Yep. All fantastic points. I would say that, when I first started, oral sedation was all I really knew. And to be frank, I didn't really know a whole lot about it. And I was definitely very slow. So I think when I first started, I was at least an hour and a half, if not 2 hours. I may even be generous with that per arch. And I definitely know, that sort of rodeo you start riding when you're trying to finish up a lower arch and you've not been the fastest surgeon. And the Halcyon or the Ativan or whatever you used is clearly, ran its course. And, I can definitely relate to the issues you're having. Now I can regularly do it on oral sedation. It's not a huge deal. I also do CRNAs as well. But yeah, I think the name of the game with oral sedation is definitely speed, especially if you're doing some full arch. But what about you, Briskie?
I started about 2 years after my residency is when I started doing oral sedation. And I think it was due to mainly just 2 reasons. One, it was to decrease the patient's, fears, anxieties, any phobias that they have, but also allow me to do some more work, because in the beginning, when you're just doing implants or wisdom teeth, you're actually nervous yourself. Yeah. So it's kind of nice to have the patient a little bit sedated and they can't read you. They can't read if you're nervous, right? Or if you do take that extra little bit of time, or you do need to talk about the procedure a little bit with your assistant, or all of those. I think it was a really big clinical ability, constructively way for me to get better clinically at a very fast pace. And then also move you from maybe producing 50, 60, 70K all the way to breaking 100K, right? That's kind of where you start to see that swing from you maybe producing 60 to 70 to over 100, because now you're able to do full mouth dentistry or all 4 quads of fillings, right? And some wisdom teeth and some root canals, right? Yeah. All under one visit, which is an amazing service to the patient.
For sure. And I may have missed it, but when you started 2 years after residency, did you go straight into IV or were you running oral at the time?
Oral first. First.
Okay. Yep. And I think it's important to discuss what that really means as well, because, how different states define, minimal versus moderate sedation. It couldn't be more different depending on where you're at.
Yeah. Like most states will say, hey, you can give 1 time medication dosage of this specific medication, usually Halcion or maybe lorazepam or maybe a Xanax, just one dose. But not every state, just like you said, is like that. Ours is, if you don't have a license for mild oral sedation, then you can only give one pill and one tab. That is just not enough for 99% of patients to really be sedated enough to get through anything. So at that point, that's when, at least for our state, we have to apply for a mild oral sedation license, and that allows you to prescribe an MRD or max dosage of 0.5 milligrams of triazolam. And then we'll also prescribe some drugs like Valium the night before. And this is a kind of ways, because in Colorado, you cannot multi-dose, which means in that period of that 24 hours, you can't give them multiple different types of medications. So the way around it is, if you give them some medications the night before, right, to decrease their anxiety, allow them to sleep a little bit better. That way, the half-life on Valium is like 16 hours. Right.
Some say it's even longer. Some studies will say it's like 72. It's crazy.
So that way they show up a little bit, much more comfortable than by the time you actually give your MRD of the 0.5, they are just happy as ever.
Yeah, it's great. It's great. Yeah, just to provide some contrast. So in Georgia, you don't need any type of certification to perform minimal sedation. So they don't use the word mild, they call it minimal. And it's much more liberal. It's actually, you can do up to the MRD of say like Halcyon, and then you can actually give another supplemental dose later on throughout the procedure that's half the MRD. So you can actually give really up to 0.75 Halcyon without a moderate conscious sedation permit. But then, funny enough, like while they seem like they're being very liberal with sedation, when it comes to IV sedation, you have to, as the dentist, be certified in IV sedation just to have another provider come in to do it. So I have to, I did 3 weekends and 20 cases to be IV sedation certified, just so I could have a CRNA come in and then just do the whole thing without any input from me whatsoever, as if I'm supposed to police him somehow. And then general anesthesia is completely out the window. But we'll get to that when we get there.
I think you guys touched on a really important point, though. Based on your state and how the regulations are all over the place, it's going to really dictate if you even decide to do oral sedation or not. If you can give them 0.5 a Halcyon, you're kind of doing general dentistry and maybe wisdom teeth and maybe a single implant. And this is not for full arch at all. If you can multi-dose and you can, some people are using Ambien now. Some people are using Norc. I heard about an Ambien protocol. I've never done it, so I'm not going to get behind the podium and say it. And I also was quizzing my CRNA on it. He was like, I can see how it could work.
Wow.
So again, anyone listening, do your due diligence. I've never used Ambien on a patient, clinically speaking. But then there's giving Norco to people. There's that cocktail. There's the hydroxyzine and Benadryl cocktail. So if you can get in there and you can get, creative with it and control your patient with oral sedation, it becomes a little easier to justify it for, more major surgical procedures from a dental perspective. But then, IV. If you can give them one dose, get IV certified. Just get ahead of the curve.
Yeah, for sure. And so if we're going to transition and talking about IV a little bit, so are you guys regularly doing IV sedation? And if you are you doing it yourself for your own cases?
Yes. So currently speaking, I'm doing my own IV for ASA 1s and 1.5s and some 2s. But then as soon as you get to like the 2.1, 2.2, I know there's not a real classification. I'm just going off my gut feel. At that point, I'm considering CRNAs very strongly, just because, a lot of patients who need full arch, they're not the epitome of health, right? There's pulmonary issues, there's cardiovascular issues. Cardiovascular issues deal with perfusion. It deals with how the body's going to get blood flow to the liver for hepatic metabolization. So all of that goes into play with how these patients are going to be evaluated. And for the vast majority of the time, these full arch cases should be one person managing airway and one person doing the surgery. Now, other than that, if they're ASA 1 or 2 and they're healthy and they're just a smoker, and not like a 10-pack a day smoker, go for it. And then I do my own IVs on cases where I think they're layups. If I'm like, dude, I'm going to be in and out of this thing, I'll drop the IV. Fentanyl, Versed, because that's all I can do in Colorado. give them some Dex, give them some Toradol. And then I'm not really screwing around Presidex just yet. It's looking super interesting.
It's great.
I know a lot of guys who are using it.
Yeah.
And so I think that's going to be the next thing I'm going to start to play around with. But they're going to go bradycardic very quickly, and
it's weird,
and you got to kind of just be prepared for that too.
Yeah. How about you, Briskie?
Exact same, actually. Dune and I agree on this 100%. Dune is usually the slightly more risque than I am, but we're actually right on the same level on this.
Okay.
We both took IV together and did Zygos together and lots of stuff. And throughout the whole process, we were like, yeah, we're going to get our IV. And we're going to do Zygo cases with our IV, and we're going to do all our full arches cases by ourselves with our IV. And what we quickly came to figure out was that wasn't actually the most logical or reasonable decision.
Yeah.
And we'd be happy to explain to you like our thought process on that.
Please.
But yeah, for me, I would rather just do some easy layups, like Dr. Dhoon was just saying. If it's a really, really healthy patient, sure, we could do an arch. I can do an arch in way under an hour nowadays.
Yeah.
So I could just very quickly get it done. But for me, I would rather have a CRNA watching the person's medical history while I quickly get the surgery done and wrap it up. Because nowadays, especially in our state, these CRNAs are actually very affordable for 2-hour increments. And I would way rather pay, the $750 to have a very good peace of mind in the end of the day that the patient is giving the best treatment possible health-wise.
Yeah. And I think one of the most important things about it is, IV sedation, when used appropriately, should be making things better in terms of your surgery. If at any point it starts to compromise because you're having to manage a medically complex patient to where you're now compromising the outcome you get from the surgery, it makes absolutely no sense to be doing that. And especially if you're newer to the game, you need to be focusing on what you're doing as a dentist. And, I would say, generally, especially if someone is medically compromised, you need someone else to be, looking over that. So I would say don't try to, make too many goals all at one time, and don't say, okay, this is my first Zygo case, my first IV sedation case, and I'm going to do all this at one time, because it probably won't end up super great.
Yeah, you make a really good point.
Yeah.
When introducing IV to your office, do your wisdom teeth, do your singles, do your crown and bridge, do whatever you got to do, right? Do your GP stuff, right? And then after maybe a year, and you're like, okay, I know how to manage some of these events. I know if I pick up the bag, I'm not going to freak out. You kind of see things occur. If their BP gets really high, and like, okay, I got to maybe try to bust out the labetalol here, and you feel comfortable in that aspect.
Great.
Then start doing your full arches. But everything is a natural evolution. And I think with surgery, what it does is it's so forgiving sometimes that then we're like, okay, yeah, we're doing the Super Bowls type of stuff, and we can get away with it. But just remember, with airway, I mean, it's very unforgiving, right? Yeah. So you can push 2 milligrams of Versed and have them have a reaction to it, and they're otherwise healthy.
Yeah.
So just do your homework. But here's the thing. If you look at the numbers and you look at what it can do for you as a practice and the growth it can build in your practice, I was spending $300,000 a year on CRNAs, and then I looked at 2022, and we only did like 125,000 on CRNAs.
Yeah. So
by just implementing IV sedation, and we were doing more surgery last year than we were the year before. So just by implementing it into the practice, we saved $100,000 plus, and then paid for our course and our equipment and all that other stuff. So it's a huge practice builder for sure. And it builds your confidence as a clinician, and it makes you push the envelope of your own education and your skill set. So it's rewarding in that fact. But then we boil it down to the fact of always look at the classifications, look at Mallampati, look at family history, ask the right questions, and don't cut the corners, because this one's not as forgiving.
Yeah. This is when you start playing with people's actual lives, not just their smiles and how they eat and things. And you're absolutely right. Airway is that's just a different level of risk that I think a lot of dentists are not really wanting to tangle with. Even if you're kind of the cowboy that wants to be doing full arch, that's fantastic. The oral environment is fairly forgiving, as you mentioned, Dune. But yeah, I don't want to be messing with someone's ability to respire.
Yeah. And for everyone listening, we're telling you all the scary stuff. And I think I said this last time. I think I even said this on this podcast. It's like, it's not easy, but it's definitely easier than you think.
Yes, you did. Yeah.
Yeah. 90% of these like IV sedation cases are freaking layups. It's you're in, you're out. They're like, "Hey doc, are you going to get started?" You're like, "I'm actually done. It's time to go." You're welcome.
That's great.
And it's a really cool experience.
Yeah, no, I mean, I haven't done a ton on my own. I really just did what was necessary to get certified and get a CRNA in the practice. But I will say that in the 20 or so cases I did, it was really cool to sit someone down, especially when they say they have trouble. Like people always have trouble getting IVs, and then you get the IV, and you're like, yeah, it was pure luck, but I'll still take credit for it. And you just see that, anxiety just wipe away, and then when they're surprised that you're already done, that's just the coolest thing. Like you just feel like you're a magician all of a sudden. It is a very cool feeling to be able to really take that off people's shoulders and kind of change their whole relationship with dentistry, because all of a sudden they can get their stuff done and they don't have to have traumatic experiences associated with them.
Yeah. And I guess to touch on like the soft stuff, there's a dynamic in the patient's, psychology that they are willing to prepay for their entire case with IV sedation.
100%.
Like they'll put the money down, they'll show up to their appointments. There's no cancellations, or I can't say no, but there's like next to no cancellations because they've made provisions in their lives to be there for this sedation.
Yeah.
So from just a practice operations perspective, it works really, really well too. But yeah, I mean, we can dovetail into implementation of your own IV, or we can go into maybe how to find a CRNA. If you want to go down whatever rabbit hole you want to go.
No, I agree. So I did want to kind of bridge a little bit into some economics. So, Briskie, you mentioned how cheap CRNAs are in you guys' area. And you mentioned a little bit about 2-hour blocks and $750 an hour, or for 2 hours.
They charge $750 for the first 2 hours, which is great.
And then okay, fantastic. Wow, that's great. Okay, well let's talk about some selection criteria. What are you looking for in a provider?
Well, provider-wise, there are a few main groups out in the area. Actually, two of them have big groups, and they have maybe staff like 6 or 7 CRNAs. And I just want to say too, shout out to all CRNAs out there. They're like the real superheroes.
Absolutely.
Because they literally run all the hospitals.
Yeah, I know.
And they do a ton of stuff. And it's really freaking cool how knowledgeable they are with drugs in general.
Extremely.
But yeah, we have two main groups that we use. I found a third party one that kind of branched off, and I use him on the regular now. But he, we started working together a couple months ago too, but just in CRNAs in general, we've been using them for over 2 years, and just the evolution of our knowledge has greatly grown from, doing surgery to the patient might be pooling with blood in the back, and they might have, the risk for laryngospasm. How do you keep the patient dry? Just like the general position you keep them. The thing is, it's actually way more knowledge you need to learn than you really think it is. And nowadays I have this one CRNA that absolutely loves to work with me. He'll text me like, "Hey man, you got any cases coming up?" Like, let's do some stuff, because he knows like when him and I go into a room, I'm going to do the surgery effectively and quickly, and I'm going to watch for the patient as well. So I'm his favorite person, because I also watch out for the patient.
You guys similar lens.
Most of the time we're thinking about the surgery, we're not really watching the patient's airway or their position or predicting how they could have a laryngospasm. But those things are pretty cool to learn, and once you learn that, then your IV is really easy.
Yeah.
Briskie makes a really good point. Like, even if you get your own IV certification and you bring CRNAs in and you watch them work, you're going to get better
hugely
when you do your cases, and you can I learned how to tape the IV like a chevron. It's like the chevron taping. It's like all these small things you pick up, or like your dental assistants will learn when they're keeping the patient open. They're actually pulling their chin up and out also. And they're just doing everything at the same time, because we're all keyed into airway simultaneously with the surgery. And finding a CRNA group, you can contact like pediatric dentists. They do a lot of GA. They're a good resource to call, but also call friends, call surgeons, whoever, periodontists, and just see like the good reputable groups that have a good amount of CRNAs on staff, so they don't have to cancel, because there is a shortage across the board in anesthesia across the nation. Other states are feeling it like more than other ones. But if you reach out to different specialists, they'll point you in the right direction.
Cool.
Yep. There's a couple different models that I've heard. Some CRNAs will bring literally everything. They'll bring the hospital and the drugs. A lot of CRNAs will just bring their emergency stuff, and you need to supply the medications, right? We see that quite a bit too. That's by far the easiest way for the CRNA. It's way more difficult for them to stock all these medications in your own office. So that's the model that we went with. So we'll buy the drugs, we'll stock it in a double locked locker and keep track of the medications. Then the CRNA just has to come in with all the emergency equipment, and we still have all the safety stuff in our building. But it's just really smooth transition. Yeah.
Yeah, no, that's great. So I have a pretty similar, get up in my practice, and I source, just like you said, I'm sourcing the primary sedation drugs, and then they help me out with all the, emergency drugs and, other things that, tools and things they like to have on staff. I pretty much on hand, I should say, I pretty much equip the office according to, what the state of Georgia asks of me to have, for, different airway complications and things. But then they come in and they're like, actually we're going to bring in a few of things of our own. And then everyone's really comfortable to deal with, whatever may happen. And so, I totally agree. I think that's a good model. And then we also talked about, so the first 2 hours were, $750. And then what happens with any successive hours for like a larger case?
It'll be broken out at the 750, but then just at 15-minute increments.
Okay.
And then they'll hand you the invoice at the end, and you just cut them a check, and they're good to go.
Cool. Okay.
And then also some CRNAs will give you the benefit of time, and other ones will kind of round up. Yeah. So, track them in the beginning, right? Call out your start time, call out your stop time.
Right.
Just making sure you're keeping everyone honest.
Yeah. Does it start when they arrive, or does it start when the patient goes to sleep? Right?
Yeah.
It could be an hour difference right there.
And two, let's say we're talking full arch. So does it stop when the surgery is completed and now we're printing teeth and we're going to be, or, converting or whatever? Or does it stop when the patient gets dismissed and is out the door? Like, at what point do they actually stop the clock? Are they going to stay the entire time? What's the appropriate way to do that?
Yeah, my guys, they stop the clock when we wake the patient up. But it's not necessarily like IV's out, and now sometimes the patients are taking a longer period of time to just wake up.
Yeah,
they're not running the clock on that.
Okay,
they stop the clock when they're like, IV's out, there's no more meds, this patient's waking up. But if it takes them an extra hour to wake up, I'm not getting billed for an hour just for them to babysit. I'm paying for the service, not them sitting in a room.
Yeah, maybe they use Precedex by accident. Right. So, you never know, right? Because it could be our fault, or it could be their fault, or it could be patients. So, at the end of the day, the correct thing is to do what's best for the patient, which is to not charge them for that lag time. Yeah.
Always. Yeah, that makes sense. Okay. So we've covered, how to, find a good CRNA. I think that's great. Dhoon, I think you had another suggestion for something else we could dovetail into that.
It's potentially just the economics of it. How you guys want to set up your own practices and how you want to bill. If you're a Medicaid practice, you can bill your own IV sedation. I think it's 45 minutes or some version of that where you can get, Medicaid wisdom teeth very profitable. And if we're talking about full arch, typically you're not doing full arch on Medicaid patients and billing that. So you just got to figure out your hourly rate. I'm $500 for the case, but if it's a longer case, then I'm going to charge, on 15-minute increments above 500. And then with the CRNAs, I charge the patient $1,000 per 2-hour increment, and then the, so on and so forth above, to just make it expensive enough to cover the cost of the medications and the cost of every other ancillary thing I need, like a payroll for a dental assistant to sit in a room for an hour and a half after the fact and kind of babysit too. Yeah,
that's a great point, because there's so many other things that factor in than just a CRNA's time. Keeping these drugs stocked and, the monitoring and all the other politics that kind of go around managing that case appropriately. Like, you're absolutely right. You kind of do have to give yourself a little bit of wiggle room for sure. Protect your bottom line. I agree with that.
Do you have a recovery room? Like, did you build for anyone listening who did acquisition, maybe who didn't plan for full arch?
Yeah.
Did you construct a small little room that's recovery, or do you have to give them op time? And then you have to look at your cost of the operatory per hour of what your productivity could be and what could be in that room versus a recovering patient.
Yeah.
And then you got to look at all the economics on that end too. So just remember, there's cost to heating and cooling a facility. There's cost in heating and cooling of an operatory. There's cost for payroll. There's cost for everything these days, and right now, certain economies, obviously, it's 2023 March, but the cost of everything is going up. Every vendor is charging more. So you just got to make sure you protect yourself and charge the patients appropriately.
For sure. For sure. So I think that, in us talking about both oral and IV sedation, there's probably going to be a lot of people listening that are looking to get in the full arch game and figure, okay, well, adjunctively, I need to be looking at, some sedation courses. So starting with the role of oral conscious, which I assume that, would you guys kind of recommend that people go and do oral conscious sedation courses first prior to going to IV? Or would you say IV just kind of supersedes that if you think you're going there eventually anyway?
I'd say if you're hesitant, like extremely hesitant, maybe you're a year out. I'd say just do oral first. But if you're already doing some of these procedures like wisdom teeth, or you're already doing some implants, I would just go for the IV right away.
Okay.
Because the benefits will just greatly outweigh it. Plus, too, when you have that license, you could technically give that medication already. So,
you're right. Yeah.
Right. Why don't you just go for it and do the IV? But if you're a doctor where you're still figuring out do I even want to do surgery? Right? Maybe don't take the IV yet. Just take the oral sedation class. But anyone that's already proficiently doing some wisdom teeth or some bone grafting, I would just do IV right away.
Sure. Yeah, I agree with Briskie. The only thing I'll add on to that is it's strictly financial.
Yeah.
A lot of younger docs, to get into the oral sedation game, maybe it costs you $5,000 max.
Not much.
To get into IV, right? It's going to cost you $35 to $50 after all the equipment and courses and time and all the weekends minimum.
Yeah.
And then training of the team and all of that. So from a strictly financial perspective, oral sedation will get you into the game sooner.
Yeah.
And then you make your revenue by learning how to do wisdom teeth and full arch and implants and sinuses. That's going to be revenue generating for you to then pay for your future IV course.
Sure.
But if you have the money and you're ready to go, if I was to do this differently, I'd start IV from day one if money wasn't a factor for me back then.
Okay.
And that would be my evolution. And the cool thing about IV courses now is the way we set it up, at least in our program, is going to be the first 2 courses are virtual. And so that way you don't have to miss all this production time from the office. We set it up in a way where that works. And then you have to come in and do some hands-on mannequin work and whatnot. And then you get your 20 patient clinical, which is, required by the ADA and all the regulatory boards. But at the end of the day, we can save you the hassle of gathering 40 hours and having to fly out, because it was tough. I had 3 or I have 3 kids, and doing all the weekends away with all the kids and all that stuff, it did get old.
Yeah. No, it's a lot. When I did mine, which I love my course, I actually still keep up with all the doctors that were in there, and we've been very close, and you really get a sense of community from it because you spend a lot of time with these people. But I had to drive up to Raleigh like 3 weekends in a row. Like I'd work Monday through Thursday, and then Thursday evening I'd be driving up to Raleigh. That's about an 8-hour drive for me. Wow. I did that 3 weekends in a row. So it was literally just like 3 straight weeks, no days off at all. And that was a lot. And there were virtual components too, but there was a lot of in-person, didactic and exercises. And, I can't recommend enough. It was Conscious Sedation Consulting, very high value course. It was taught by a self-described.
Randy,
you know him. Yeah, you know Randy.
Yeah. We took Randy's course too.
Oh, perfect.
He's a really, really funny guy.
That's amazing. Yeah, it's a great course. Yeah. Huge experience.
On our way back from San Diego, we did a bunch of filming for the IV sedation. Mm-hmm. Randy was actually on the same plane as me on Southwest. He goes, Briskie, what's up?
That's funny.
Yeah.
He's a great guy.
He's a good guy. He's really funny. Get along with him.
Yeah, great course. I can't recommend it enough. But
so Tyler, question for you.
Please.
How many prophies or fillings did you have to do during the sedation trials? It's 20 cases.
Let's see. We did a fair amount of fillings. As far as prophies, I think I probably did. So we kind of like worked in pairs, and I would say that I probably personally did about 4 or 5. Something like that. Yeah, probably something. It was mostly small procedures. I prefer the surgical stuff because my background, like I've done 1 crown since I graduated. So like any general dentistry was not a really responsible thing for me to be doing at the time. So unfortunately my partner did a lot of that. And so if it was surgical, I'd do that. And then if it was like fillings or something, then he would be doing it. Shout out.
And I'm assuming that like all the patients that you did, the Versed on 2 milligrams or 50 mics of fentanyl max. Well, all their protective reflexes are intact, right?
Oh yeah, it was super light. Yeah, super light. Yeah.
So the part that we're trying to change a little bit in our course is trying to give a little bit of more real life situations.
Sure.
So a part of our curriculum is actually going to be doing IV sedation cases on real life patients in terms of wisdom teeth. So we're actually going to be doing some of these IV sedation patients during our wisdom teeth courses and our regular implant courses. Because we're going to try to get a little mixture in there where, maybe 7 or 8 of them, or at least a third of them or more, are going to be on real life situations. Because when I got back, me and Dhoon sat in the room. We're like, hey, well, how much meds can we really give?
Yeah.
So we were kind of nervous, right? Like, I don't know how much to push the boundary. And we're not trying to push the boundary, but we're trying to make the patient comfortable, right? Comfortable and without fear, without anxiety to undergo a large procedure. So I think part of what I'm excited about, and hopefully Dr. Dhoon's just as excited as me, which I think he is, is trying to give that really tailored, really IV sedation experience to make sure you go home really understanding how much meds to actually give the patient.
Yeah. I think that's huge. I mean, I loved the course, but it was like, it was kind of a madhouse. Like, you have a whole lot of doctors that are running on sedation, and you can totally understand why it's a very conservative, dosage. We're being super, super careful. Like, you get where that comes from. But actually in that group I was talking about, we still have a group chat with all the doctors that were there. And one of them said today, he said, I just used 500 mics of fentanyl and 8 grams of Versed, and the patient was totally unfazed. And I remember actually during the course, don't let me say that, but it's just, that is the reality, that some people are going to take so much more than what would, be generally considered appropriate in that sort of setting. So I think it's really cool that you guys are trying to do that. And just for clarification, so when you're doing these like wisdom teeth and implant procedures during those courses, is it like the same doctor that's doing both of that? Or is it like one doctor learning IV, the other one's doing implant, or how are you guys?
Yeah, I'm glad you asked about that. So the new building we're building for Colorado Surgical is going to have 2 conference rooms in the basement. And so one can hold 40 people, one can hold 30 people.
Wow, okay.
So while one group of docs is learning wisdom teeth or single implants or these like 2-hour procedures, the simultaneous group of our anesthesiology attendees will be in the 30-person room learning simultaneously with that group of whether CRNAs or docs that do IV sedation or, anesthesiologists, whoever is going to be proctoring that version of that course.
Cool.
Then they all go upstairs and the patient is going to get sedated by the attendee for anesthesia, and the doc who signed up for wisdom teeth is going to slick some wisdom teeth.
Oh, that's so cool. Yeah, I think that's a brilliant idea to kind of bring in that real environment, because I feel like a lot of courses are they're more engineered for technique. They want you to be able to go through the paces, the monitoring, the administration of the IV, just, get used to that sort of just mental checklist that you have to run through in order to run a case. But that real life implementation is not usually the focus of these courses. So I think it's beautiful that you guys are doing that. It's really cool.
Yeah, and we're excited for the patient because it's like now the patient actually gets IV sedation.
There's value. Yeah.
Like, how cool is that, right? And then now all the doctors can actually learn effectively with their implants or wisdom teeth because the patient's not, we're not so concerned about saying, here's a little pinch, or I'm going to cut the bone, or the patient's eyes get all red. Like, what are you going to do? Right?
Yeah. There's a lot of like off limits words in my office, like blade, scalpel. We don't say that. It's like 15 or there's you can't say blood. It's heme, or
it's heme.
Maybe I just say red. There's some red right here. I want you to take care of.
Here comes Mr. Ouchie.
Don't say that. Mr. Ouchie. Yeah. That's funny.
One thing I wanted to make note of as well is what we're going to do with that I think is unique to the industry, but I can't say that with supreme confidence, is that if you have oral sedation license, a lot of docs, they call us and we do coaching calls for various reasons. But they're not afraid, but concerned about what to do from an oral sedation perspective in terms of dosing when they get home. They've never done a live case. So we're actually going to be opening up some spots for docs to come in and do live patient oral sedation administration to get reps on that end if you're in the oral sedation realm. Yeah. And I don't know if that's completely unique, but it's something I wish I had. And we have the capacity for it. We have 18 operatories. Yeah. So we have the capacity for several ops to be dedicated to that procedure.
It's funny, I never thought about it, but I don't know of any oral sedation course where there's actually a live patient portion of it.
Yeah, it wouldn't be like worth the time based on the state, but but when I came home, I was like, man, can I really give them an extra dose? What's 0.75 going to do? What's 3.3575 going to do? And just kind of like watching these people over an actual procedure, it matters and it helps.
It does to get those reps in and just kind of see how that can be different on different people, and even how it can be different on the same people. I know that's not going to be probably done in the course, but that is something amazing. I think you guys may have heard the story too. Randy told us a story where he heard about a doctor. It wasn't one that took his course, but it was a doctor that had started off a patient on just like a single dose of Halcyon, and she'd been taking a bunch of antidepressants and, sleeping pills and stuff like that. That just a, complex mental health history, I suppose. And just nothing was working. So he just kind of keeps giving her more Halcyon. And eventually, like over the course of about, 2.5 hours to get this patient, semi-comfortable, she'd had 8 tablets of Halcyon. And then that, got through it, whatever. She went home. Everything was fine. The next time he saw her, he just went ahead and gave her 8 tablets of Halcyon. And she had taken it at home like prior to even getting to the office, and she never got there. And they like found her like they went to the house to check on her, like do a wellness check, I guess, and she was like naked in her closet, and she was fine. I mean, she lived, but it was just insane, like absolutely absurd. So it's just, real life experiences, understanding how dynamic oral sedation can really be in different people on different days, just depending on their own chemistry. That's huge. I mean, it's not as simple as, dose effect. It doesn't work like that. That whole low and slow titrate to effect, there's no option for that. So yeah, you have to get pretty versed with, kind of knowing how those cases are going to go.
I'm
glad they did a wellness check. Like,
oh my God.
That was a good move.
Good call. Didn't just no show, no call. It was like, there might be a problem here.
Yeah. I guess to touch base on that. Yeah. Doing oral sedation is the only time I've had patients come in and complain at how long they stayed sedated into the next day, especially elderly patients. And
they don't
not knowing what's happening. And then IV sedation, I've never had anyone complain about the duration and the elongated effect of the amnesia component of it. Yeah. So there's a beauty in the IV component where you'll never get that with oral sedation, especially if they cross 65 on age.
That's a great point. That's a really good point.
Tyler, I got one for you. One where there's 2 different types of person. So I had one guy. Actually, this is 2 different times this has happened now, and they're all on male patients. Where I had a patient, normal MRD of medication, things went great. In the second visit, one was like a couple months later, one was like another couple years later. The patient was actually on steroids, muscle steroids. So they're
like
going
anabolics
to the gym,
or
anabolic steroids. Yeah. And the patient went completely erratic in the chair and at home, and actually started punching holes in the wall.
Oh my God.
And had some kind of weird reactions to it. So I would definitely ask anyone that might look like they're on the juice to make sure that they're not taking any steroids that could be counteracting with the medications. I don't know the exact reason why the oral medication had that specific effect on that, but it's happened twice. And as soon as it happened that second time, like, oh my gosh, this is something that, I'm definitely going to tell people about.
On the juicy guy, had you ever the juicy guy? had you ever tried IV sedation on him?
No, we just did oral and things went great. Okay. And months later, he started taking steroids, and boom, it was some crazy reaction.
That is wild. That's so weird.
I've also heard about people on like chronic THC use and on people doing vapes, like the nicotine vapes. Yeah, I'm hearing they're getting super resistant as well.
Really, really tough. I've had that personally. I had a patient, and I probably should have known better. He was Rastafarian. And I had a very frank conversation with him about it, and I was like, I just need, if we're gonna do this, I need you to just lay off it, at least for a week or two prior to, because there are some interactions there, and I don't know whether or not he did or not. I really don't. I suspect that he did not take time off, and that was a rough one. That was like, we're cleaning urine off the chair and he was bucking around. And I mean, I really couldn't, I actually had to finish up the surgery the next time unsedated, and he did fine. But it was better to not even sedate in that case, because it was literally, it was inoperable. That's a huge one, big red flag.
Yeah. Marijuana
also,
use. Yeah. Go first.
Oh, I was going to pivot into asking about pregnancies, because I got a bad scare on someone.
Yeah.
So we ask them, we tell them like, hey, are you pregnant? Is there any chance? She's like, no. We do the wisdom teeth. She comes back. Oh, by the way, I found out recently I'm pregnant.
God.
And so it depends on your risk tolerance. And then I did the lit review on Versed. Because fentanyl is not necessarily an issue, but Versed is.
Yeah, it's
but with cleft lip and palate, it's like, 1%, and with miscarriage, it's like 1%. So it's very low. It's very, very low,
but not
it's
zero.
Present, and it's not zero, and it's arguably, in most households, the most important thing to that person is their child.
Yeah.
So again, you may want to consider having pregnancy tests in the office. And if they're anyone of childbearing age, and that can be a very young age too, that you just got to have a real conversation.
Yeah.
Or very old age too.
Or very old age too.
Yeah.
You may have to say, hey, go to the bathroom, take a pregnancy test. They have to go to the bathroom before they get sedated anyway, so their bladder is clear. So they're not like, fighting a full bladder. You might as well ask them to do that. And you have to say it with tact, because I had actually a couple sleepless nights until we found out that everything was fine from the OB.
No, I bet. One of the guys from my group is probably a month or two ago. He messaged us about it, and we had a conversation about how many of us were actually doing the pregnancy tests on women prior to doing the sedation, because it was just kind of the thing where it was like, okay, is this just like being super, super cautious, or is this like a reasonable thing to need to do? And he was following that protocol. And I think it was like a 39-year-old woman that had just sworn up and down there was just no way. And he was about to run the sedation, and she had taken the test, and sure enough, she was pregnant. And it was a very rough day, but oh my God, he was just thanking his stars that he actually followed that advice. And that's a very real thing. But yeah, you can get some surprises. You do enough of this, I'm sure.
Yeah. Yep. And
just have your treatment planner have that discussion, or the treatment coordinator have it. You don't want to be the dentist in this new age telling the young female to take a pregnancy test. Like, hey, what's wrong with you? So just have make sure you tell them before.
That's great.
Visit, and
else tell them. Do it during the whole like consents conversation. When they're signing consents and things, and then you never even have to mention it. That's great. Yep. Yeah, that's
avoid
good.
awkward conversations.
At all costs, because I'm not very good with them. But so one thing we haven't touched on, because we talked a whole lot about IV and oral. So I'm curious, is general anesthesia in you guys practice at all? Is that something you have experience with or opinions on?
Yeah, sometimes the case is complex enough where the anesthesiologist does the review and they're like, hey, we want to intubate. And so if that's the scenario, I bring in a dental anesthesiologist. I pass on the cost to the patient, because it's basically double a CRNA, $750 for 1 hour versus $750 for 2 hours for the CRNA. And then they'll do a nasal intubation.
Okay.
Someone told me once that they've had a flexible LMA that they've moved back and forth. The LMA goes into the oral airway. But I just don't see how that could necessarily work. So for me, in my experience and what I've had the dental anesthesiologist do, is it's
always nasal.
Always.
Yeah. That's the only way I've ever seen it. Yeah.
Anyone with special needs, right? Will you get the adults or teenagers with special needs? They need the BGA. They need to be protected, especially with their little short necks, right? And their questionable airways. They need to be airway sedated. Pedo patients, they need to be airway sedated as well.
Okay.
And then also we would recommend doing it for patients where they're getting like a zygoma, like a surgery, more intense type of surgery as well.
Okay.
Those are the ones that I would recommend it for. I think it 100% has its place. The dental anesthesiologists are freaking awesome. And if you have a pretty questionable case, or if your CRNA gives you a little sigh, like, ooh, I don't know if I would just call your dental anesthesiologist in to make sure that that patient's healthy, right? This is not worth the risk. these days.
Yeah, no, I totally agree. I've done one case under general anesthesia, not here in Georgia. It's not even an option here. I will say that from just a purely surgical perspective, it was amazing. I mean, you're literally, I mean, it's like, pardon the phrase, but it's like working on a cadaver. I mean, you're getting no feedback at all. It's incredible,
awesome.
Actually.
The whole mouth can pool with blood. There's nothing getting into the airway. There's nothing getting around the vocal cords. No. You have a green light to do anything you want to do. But here's the thing. It's like you don't always need to push people that deep.
No.
And the cost to the practice. I'm from the standpoint of always looking at profitability of procedures, calculating all this stuff. And the cost of GA sometimes is not necessary.
Yeah.
But it's fun. I would say do one a month or one a quarter, depending on it, just so you can have that experience every once in a while.
It's pretty cool. Yeah.
Dhoon's very good at watching the overhead. Sometimes I'll catch him eating lunch and he's counting how many circles of quinoa is in his lunch. Just to make sure he got the
supplies,
value.
You need that though, man. You got to have somebody that's crunching numbers. That's great. It's
all about the EBITDA.
Yeah, of course. So I mean, that's great. I mean, I think just our full synopsis here, we've kind of run through the full gamut of oral sedation, IV sedation, and we touched on general anesthesia as well. We kind of gave people an idea of, where they should turn and how they should be thinking about courses and what they should be going through. Are there any other things that you guys can think of that are kind of relevant topics for that? Maybe we should talk a little bit about, what kind of, medical contraindications that we're really looking at. Patients that we really do need to be considering, sedation a little bit more carefully for.
Yeah, absolutely. So, I mean, number one is you got to do like an adequate health history review. Yeah. You just have to do a review of systems. Mm-hmm. You have to ask the questions like we covered, pregnancies and whatnot. You got to look at mal and potty. Mm-hmm. You got to look at range of motion of the jaw when they open up to make sure. A simple rule of thumb is 3 fingers. Anesthesiologist, if you can't get 3 fingers in there, you can't intubate someone. So if they have a limited range of motion, it's going to make your surgery harder. But then at the same time, it's a sedation issue too. Do they have any type of liver issues? Because that's where the vast majority is getting metabolized. Yeah. Cardiovascular, pulmonary, et cetera, et cetera. I think heavy smokers, any type of COPD, all that stuff is going to be an issue as well. They go hypoxic. Sleep apnea, circumference of the neck. Is their neck? Do they look like a retired linebacker or like lineman? They're going to have a hard time breathing when they're out for the count. So that's like my bird's eye view review of systems. That's great. And then of course it's going to be nuanced with every other person's their overall presentation.
Sure.
Yeah, for sure. So just basically, like for me, asthma, emphysema, right? Yeah. Pneumonia. Do they have tuberculosis? Any pulmonary diseases? Do they smoke? Do they not smoke? What's their actual alcohol usage? Do they have any liver diseases, renal diseases? Right? Just like little things like that. Ask them about their previous exposures for stuff. Like, have they had previous nausea and vomiting during surgery? Right? Any difficulty in administering anesthesia? Are they on any long-term pain meds and they have these little spider veins that you're not going to even get the IV started in? Right? Difficulty waking up, right? There's just delayed waking up, all these different little questions. But for the most part, I think it's really the actual breathing issues, right? Like asthma, emphysema, COPD type of stuff.
Obstructive sleep apnea.
Big smokers, sleep apnea patients, like linebackers, like Dr. Dhoon said, male or female. And then,
what I like to do is I like to put a pulse ox, and I actually do this on every patient in the practice, put a pulse ox on their finger, and then we lay them back, because most physicians aren't going to lay their patient down and put a pulse ox on their finger. They're usually sitting upright in the family med's office. Yeah. So then they're like, oh yeah, I'm a 95. Well, you lay them back and they're a 92.
It's a different story.
Well, you're like, okay, well, laying down, you're wide awake, you're guarding your airway, you're at a 92. Let's get a sleep test. Let's talk about treating your apnea. Let's roll in the cost of your sleep appliance, which is, $3,000 to $5,000, whatever you want to charge, into the financing for your full arch case. And now we're not asking for more money later. You've automatically financed the whole thing. So maybe it's, if you're 25 in arch, maybe you're financing $55,000. because you've done your sleep test ahead of time, but now your CRNAs know about the apnea happening for the case as well. So you're prepared from an anesthesia perspective. You've increased your revenue of the overall case. You've protected your prosthetic with a sleep appliance, and you've also opened up the patient's airway after the reconstructive procedure is done.
Yeah.
Wow. And then at the same time, it's going to dictate, if they have apnea, you're going to select multi-units that allow enough space for the tongue, because sometimes you got to flip a 17 around to create a little bit more room for the tongue.
You bet.
And for, how you adjust occlusion and whatnot. So, I mean, the sleep test ahead of time tells you a lot, just besides for anesthesia. It tells you a lot for so many moving parts.
Wow. I have honestly, I think you've alluded to, in one of our episodes, you alluded to sleep in the management of some of these cases, and I've never heard anyone actually like integrate a full mouth rehabilitation, especially with fixed or something like that, into the sleep. I think that's really cool that you're actually looking at that on the front end. And I mean, so many of my patients have sleep apnea, whether they know it or they don't. I might find it out when I sedate them and I just see them just obstructing and, having those issues, and I'm talking to them about it afterwards, and, they're going to look at a sleep study. I love that you're doing that on the front end. I think that's really smart.
Yeah, there's a really cool company, and I wish I got a kickback for it because I've sent them so many people at this point, but I don't. It's called Sleep Image, and it's just a ring they wear. And you can it's not diagnostic. You cannot get a sleep physician to sign off on it. Yeah. But it's just a ring they wear. I think the overall cost of the practice is $10 per test. You pay $300 for a ring, and then they're reusable, of course. So it's just $10 to the practice, and you get the results and the risk factors of where they are. And it spits out an AHI that's kind of close, but there's a delta. There's a standard deviation of where they fall. Yeah. But it'll still spit out AHI, still spit out like oxygenation and all that stuff, and quality of sleep.
Very cool.
And you can do that before every surgery.
Yeah, I mean, I think that's super smart. That's great. I mean, like you said, I mean, that's it. While we're on the subject of sedation, I mean, what could be more important than talking about how they're breathing when they're not entirely conscious, which is exactly what you're going to be inducing. So that makes all the more sense.
And then after that, I mean, that's kind of it. I mean, really, at the end of the day, I think I'll leave everyone with the final.
Let's do it.
Just get into sedation. If you're doing surgery, you will absolutely unequivocally end up at this decision of implementing sedation in your practice. From a legislative perspective, we're seeing them tighten it up, where if you're going to be offering oral sedation, some states you have to be trained at a level above. If you're going to have anesthesiologists in your practice, you're going to need the license too. It's just the way the pendulum is swinging on regulation for this is going to dictate that if you're a dentist doing surgery in your practice, you're going to need it. And then also what you get out of it from the constant striving of trying to learn and be better at what you do and offer a better service and just like push the envelope from a knowledge perspective. It's really gratifying to implement this into the practice, and it moves the needle for the patients in a major way.
I agree. Briskie?
I mean, overall, I would just really encourage everyone to do one or the other, oral or IV in general.
Just get started.
For me, I think maybe I'm just like overly empathetic for my patients, but I feel bad for my patients if they're going through some struggle, and that's something that I could actually fix for them. Yeah. In the end of the day, right? Whether that be them being nervous about just the shot or just the length of the procedure. But at the end of the day, I don't ever want to be the dentist that just only does one tooth at a time. I want to get the patient to the end of their treatment plan as fast as possible. So that way they return as a very happy hygiene patient.
Yeah, no, that's a great point too. And I think that, especially when we're talking about full arch patients, there's been so many different obstacles in that person's life that have prevented them from doing anything about their situation. And one of the main ones is anxiety. I mean, I can't even tell you how many of my patients are coming into practice and they can't even look me in the eye. And I think just being able to dissipate that barrier and stop that from, keeping them from getting to where they want to go and improving their life. It's fantastic. And to also piggyback off what Dhoon was saying too, I think that, in pushing yourself to really learn and understand sedation and administer it to your patients, you're encouraging yourself to be more of a medical doctor as well, and not just focus on teeth and engineering and the mechanics of full arch or whatever it is that you're doing. And you're really, you're going to have to go back to the fundamentals of, how the body works and how best to treat it when you're performing, relatively major surgery on it. So, I think this is a great way to push your boundaries, to benefit your patients and grow your practice. Ultimately, you got to protect that EBITDA, just like Dhoon says. So,
amen. And then protect your staff, because when they come in hungover and they can't work a shift, you plug them into the IV and get them to work.
That's right. You hang them in it. That's perfect.
Too.
If a patient, if you're on an airplane and someone passes out and they ask, "Hey, is there a doctor on board?" Just don't raise your hand for that one. Everything else you're good on.
There's always going to be a real doctor there, so the odds are you're not going to have to get involved.
So I'll actually close with an anecdote that's totally irrelevant, but now it is. So so my girlfriend is an ER nurse, and I joke with her all the time that between the two of us, the real doctor is her. And if we're ever on an airplane, she's the one that needs to stand up. I'm not going to stand up. I'm not going to bother. And she's told me, I got to give credit to her. She really respects that I'm a doctor and I'm a dentist, and I appreciate that. But we actually ran into that situation, luck would have it. And yeah, we were on the plane, and this was like shortly after we'd had this conversation, and we're on the plane, and they come over the intercom. There's like, is there a doctor or medical personnel on board? And she looks at me and she's like, "Oh, you got to go." And I'm like, we've had this talk before. And I tell her, I'm like, "Look, Raina, we've had this talk before. This is a real situation. You really do need to go up there. You deal with this every single day." And she was like, "Can you at least come with me?" And I was like, "Okay, fine. I'll come with you." So she gets up. She had the aisle seat, so she was in front of me. It looks like we just lost Dhoon, but I'll tell the story anyway. So she gets up and she goes towards the front of the plane. And I'm walking closely behind her, and there's actually several nurses around this passenger, or I'll say patient, I guess. And she's, unconscious, and they're getting vitals, and they're running all this stuff, and the patient's like coming to and then kind of going out. It looked more like a psychotic episode, if anything. But the one of the flight attendants is coming by, and she sees like a whole gaggle of people trying to attend to the situation. She's taking stock of who's who and what do they do and stuff, and she's pointing at them. And one of them's an oncologist, the other one's like a ER nurse, the other one's works in the NICU or something like that. A lot of nurses were there, and then I think one of them might have been a physician or something. And then she looks at me and she's like, "What do you do?" And I'm like, "I'm a dentist. I do some surgery and stuff." She was like, "Sir," she says, "Sir, can you go back to your seat, or do I need to help you find it?" I mean, she literally just absolutely floored me. And I had no issue with this because I didn't want to be there in the first place. And so she tells me to go back, and Raina, like, she has a stethoscope in her ear. She's not even paying attention. And I go back to my seat, and then she looks up and she turns around to talk to me and ask me a question. She sees that I'm not there, and then she's like looking around, and I just wave at her, and I just get so much vindication from this, because I should have never stood up. And I'm telling dentists in the future, just avoid for yourself the potential embarrassment. And Dhoon is right back.
And the crazy part is, like, you were ACLS certified, right?
Yeah,
you know all these things.
I do.
But the perception of it was that of that. And hey, I'm okay with that. I don't want someone to try to seek vengeance on me later on because I didn't resuscitate them fast enough.
Yeah. I was like, no problem. No problem. I know. I did not forget my seat. I'll go right back to it.
Yep. 100%. Yeah.
All right, so we'll close with that one. But guys, I really appreciate you coming on. Again, this was I learned so much from this episode, and I know our audience is too. And I'm really glad that you guys are coming back on for more. And I know that there's just so much more you have to share. So I'm really looking forward to next time. I appreciate it.
Man, we appreciate the hospitality, dude. These are fun conversations.
They are.
Really, really enjoy it.
They are. Until next time.
It's a lot of fun talking with you, Tyler.
For sure.
I have a really good time, man.
Likewise.